let's assume that we are doing a hip abduction. It's just an evaluation, alright? The hip joint is palpated to be here, alright? Now I ask him to abduct the hip complex, alright? And this is his pelvis, right? His waist, this is pelvis, alright? Observe, just one, observe. If you want to stand, you can stand. If you want to stand on the bench, you can stand on the bench. If you want to stand on top of the roof, you can go. It's up to you. Alright? Abduct, gentlemen. That's good. Drop it down. Alright. Abduct again. Drop it down. I want you to abduct only for around 45 degrees. Not more than that. Okay? Chacho. Do it again. How many of you observed? Drop it down. Do it again. That's good. Drop it down. Stop. Out. 1. I didn't ask you anything more than this. Get out. 1 more here. 1 more here. Right, that's good. Thank you. Hip joint, pelvis. Okay. Hip joint and pelvis. Identification, I keep my hand key on the pelvis. Abduct. Drop it down. Abduct. Drop it down. Abduct. Drop it down. Abduct. Drop it down. Abduct only for, yes. Initiation of abduction. Drop it down. Initiate abduction. When he's abducting, what is happening to this handkerchief? It's actually, it is displacing. Alright? Fine. Alright. Get down, Navi. Come on. Yes. Abduct. Drop it down. Initiate abduction only for few degrees. Down. Abduct. Down. What's happening to this? It's also moving. Was the movement for this pelvis less or more when compared to this gentleman? This is, how many of you say less? How many of you feel that the movement of this particular pelvis is less when compared to this? How many of you say this movement is more than this movement? So others have visual problems. Alright, so all of you can go and I check eye sense. So by and large, we have found 2 different scenarios. Abduction was attempted, pelvis was actually good. So you could find, can abducted now, gentlemen? Can you slightly abducted? Yeah. So when abduction was there, this, okay, now drop it, abducted, drop it, abducted. Okay, so abduction meant there was no movement in the pelvis. But when abduction was done more, then pelvis was actually getting moved more. Alright, so here, what do I do is, I put my fingers. Alright, so what is happening? So this is abduction. Then by your gluteus medius. Alright, yes? Alright, now for your pelvis to keep it stabilized, alright, you need to have this muscle to go. You call it as lumborum, and your rectus spinae, and your abdominals. They 3 has to go up to keep your pelvis stable. Got it? That's your fixator. Alright, this is your prime mover. This is your antagonist. Alright. Now I have one example here. Just get down. Now we'll come again here. Now Naveen will do abduction. Okay? He will do an abduction. And everybody look what's happening to his foot. Alright, can you abduct Naveen? Abduct, abduct, abduct. Okay? Drop it down. Right. Just relax and abduct it, Naveen. Can you abduct her? Yes? That's good. Do it again. That's good. That's a good one. So thank you very much. Can I have one more gentleman from here, please? Anybody from this side? If you permit me, I'll handle you. Thank you very much. Right. So the lower leg beneath is being bent for stability. Hip joint, pelvis, right? And I keep for identifications. Abduct, beautiful, down. Abduct only for a few range. Drop it, abduct for a few range. Movement दाएं यहाँ पर. Was there movement in the pelvis now for this girl? There was very minimal movement compared to these two gentlemen. The movement of the pelvis was not much. Abducted. Okay. Now drop it down. Can you abduct it? You can find initially there was no much of movement, and after that the movement was happening much. Alright. So this is one example. Now can you abduct it again, please? That's good about it. Yeah. Naveen, yeah, do you find the axis of the spine and the axis of the leg is straight? Spine long axis and the lower limb long axis, is it in a straight line? So what's happening to the leg now?
Forward.
Deviated towards the flexion? Yeah? Sure? Is it the same from your side? You find it is, you can come here. You can jump, I don't mind. For one time you can become a monkey. Fine. Stand here. Naveen is telling that the axis of the spine and the axis of the leg is not straight. Is it true? Is it straight like this? Or this is in front inflection? It's in front, it's inflection. Okay, fine. So you are taking the side of Naveen. That's good about it. One more, somebody from the other side. Then you have a pain and a cramp. It's fine. Alright, let's just drop down. And one more. You can visualize, you have a good eyesight. You have good eyesight? You see well? You see me? Right? I'm looking old? Yes. This is too much for us. Let's go. I'll not call you next time. I'm telling you a word. Yeah, do it up now. She's doing it again. So is it the straight? Spine and the legs are a straight line? Yeah, she did it again. I thought she will recognize it and she will take it back. Okay, but the movement pattern is like this for her. By default, when you try to abduct it, this was going into the synergists are overacting. Got it? So for her, the iliosomas is actually overacting. So Gmax is weak. Yes? Possibility hai? Right? That's good. We'll check it. Right. By the count. The mid bulk, it was not overacting. The firing, the muscle fibers are not hitting my fingers. But when the muscle fibers are hitting his fingers, it is just overacting. Okay, indicating this overacting. So this muscle has to be reduced. I have to release it. Alright, if he has a pain, probably this could be one of the factors. I should again check it up with other components also. Okay, what about the muscle activities in extension, all those things? So I should try to release in all the portions. It's not that I should release only in abduction. I should check what's happening with him in abduction, in extensions, alright, and then I have to release all those structures now. Okay, so one thing evidence was that the gluteus maximus was weak. So QL is overfiring, and the QL was overfiring in the area which was going to be a bit tender, because he said it in this area was a bit painful. Okay, when on pressure, it was quite tender, and at this area there was overaction of a muscle. Okay, when compared to the other areas. This is what we see it up in a firing sequence. Alright. Fine. What should be stabilized? Thorax. Thorax stabilization can be done by scapula stabilization, because anteriorly is stabilized by your body weight, posteriorly by your scapula. So you should find the scapula getting settled. Right? So can I just extend a leg complex, please? Right? Drop it down. Drop it down. Right. Can I just do it again? Drop it down. I have a small pillow usually, and I keep it. So if things are going on right, this must be firing, and then stabilization. Then it should come into extension. All right. If this is not firing, all right, where stability is not happening, Will she be having a proper complete leg extension, or she will have over the leg? Yes. Okay. If there is no stabilizer that is firing down, will she have a proper leg extension, or she will have exaggerated movement? Exaggerated movement. You can expect her to do thoracic extension also. Is that right? Cervicals, thorax. Alright? Fine. Can you extend the neck? Drop it down. Extend it. Drop it down. Can somebody come and put your fingers over here, please? Somebody who has not come. Yes. It's okay. It goes into your nose. Yeah. Extend your neck. Drop it down. 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 That's good. You find anything over here? Nine. So she is isolatedly using her traps. Alright? Fine. Now she is relaxed. Just put your fingers here. Can you extend your neck? Drop it down. Extend your neck. Drop it down. You find tone? Alright. So this kid has got initiations, stabilizations, and acting it up. Alright. So thank you. You have a good isolated leg extension. Anybody else who would like to check it out? Fine. Nobody is. So you should be having. Let's look at the style extension of inclusive of cervical and thoracic. We usually do. We train the patients. Style extension exercises, McKenzie's. Alright. So when you do a McKenzie, the biggest mistake we do is that we don't isolate the movement components. Alright. So instead of you isolating your cervical and thoracic, you start directly starting on from your lumbars. How many of you have identified that? No. Can I have two models here, please? Two. Please. One more. One is there. Second one. Causes for thoracic and cervicals. What should be a firing mechanism? They should fire first. Stabilization 1. They should fire first 2. But the firing should be maximum over here. And the movement should happen segmentally. Okay? Now, if the movement is not happening segmentally, it means there is movement restriction in the thoracic structures, right? Thoracics. Fine. Alright? With the permission? Quadratus lumborum. Alright? I do it here. Lift. Slowly. Down. Slowly. Down. Slowly down. Now it's better. Slowly. It's better. Right. Can lift up. Up. That's good. So what has happened? I think initially it could have found. Initially this lumbar was going more into extension. And when I started telling her slowly and slowly, this lumbar extension, lot of this increase was actually reduced, and she was only concentrating on this and this. Did you identify that? Few of you would identify it. Did you check it? Did you understand? It was actually going wrong. Did you know what was happening in the first moment? You tried. Alright. So she herself understood that something was going wrong. So she stopped using this. Let her only use particular muscle. So it indicates that probably if you're using this, but you're using this quadratus lumborum firing to be stable, but here she is trying to use the quadratus lumborum to provide more extension by pulling the thoracic cage out. So instead of you using this particular muscle, she's using this particular muscle. So she uses the quadratus lumborum to pull it up. So unfortunately, this becomes overacting. Now what will happen if this happens? When she is trying to do overacting, trying to pull both the spines like this, there is increase in lordosis. There is increase in compression. When it compresses, then naturally your multifidus becomes short. Interspinous becomes short. Quadratus lumborum becomes short. Yes, erector spinalis become short. So all the muscles become short. These are not small but firm muscles. Posterior, they are small but firm muscles. When they become short, it is difficult to get them elongated. So for them, will you go for a stretch or you go for relaxation? You go for a. But what do we do when a patient has got a correctus lumbar? When a patient has got lumbar lotus exaggerated, what do we do? We go for abdominal strengthening. We go for dorsal fascia stretching. We go for flexion of the lumbar spines. How many of us try to release those spinal extensor muscles so that when they release automatically, the muscle firing will become normal? How many of us tried that? Alright. So, by and large, if you start initiating relaxations here, creating a change, okay, so what will happen? This is not overfire. When this does not overfire, this will be a prime mover. It is only supporting you only for stabilizing things. Alright, it doesn't overfire, then you will not create the, you will not have the pain. So, by chance, do you have a pain in the back? No. You experience pain sometimes? You say, okay, we'll do about it later as of now. So this is how we actually check it for. So when a patient comes down to you with a back pain and you don't find there is no pathology, no disc, no spondylosis, no diseases, young patients who are having some difficulties and discomforts, not every time you have a biomechanical dysfunction, so your pathological dysfunction, you also have biomechanical dysfunctions. And find what's going on wrong, one by a if you have a problem in your extensor components, involve or take the particular joint or the structure into the extension and add a lateral flexion or lateral extension or the posterior side, which is right or left, depending upon that, add that side ipsilateral extension component. So that you try to take the muscle to the most shortest position, hold it for a couple of seconds, anywhere between 60 to 90 seconds, and then slowly release it by bringing it passive to neutral, not active to neutral. Once the pressure is being done after 90 seconds, bring it passive to neutral so that you are facilitating or continuing that particular reflex still in position by passively getting it into position. What does neutral is? If I do it in probably in supine lying position, but then for easy demonstration I'm giving for you. The time taken for it is around 30 to 90 seconds. Okay. Once I give the gentle pressure where the muscle is getting released or relaxed, okay, that what you found that which is found to be more superiorly or which is prominently identified. Okay, and that's you find the change in the contour bottom that will be slowly going off. You'll have to pursue for the change in the fibrous band or the tone or the increase or probably increase in the small curvature or probably your taut bands. So I'm just holding it for 30 seconds to 90 seconds. Is it painful? No? Right, fine. It's not painful for her. So what I gently do is just I just take her and if possible I take a still more into flexion. So painful. Right. So this is the range. This is the range. Okay. And I add a slight oscillation if required. Relax the muscles. Right. Fine. Now with the same pressure, right, if I just do this much, it's a counter strain technique. Alright. Almost more than 30 to 60 seconds is done. So I am slowly releasing it and getting it to the neutral. Alright. Getting it to the neutral, I'm done. Alright. I'm just again I'm closing my eyes. I mark the points. Alright. I do not know what I'm going to do. Right? SCS cervical extension. The patient is right. Imagine this is what she has got. Okay. Now we identify she has got with the trapezius right side. Okay. So what should be my pattern of movement as per this? Must be extension because it is a posterior component. It should be into extension. Should be into lateral flexion or not? Yes, should be into the extension to the right side. Alright, fine. And which is this shortening our muscle? Not this one. Alright? If It's something like no. If I slap at you, you give a response immediately. Alright. And when you know that I am going to slap you and you should not respond, even if I come down to slap you, you will not respond, you can simply keep quiet. So next time I will either not think of slapping you, or even if I slap you, you will not show me the response. It means that you become insane, you become inhibited to the stimulus. So like this, when this particular structure is being given a pressure or a pain, the inhibition, that is the muscles does not, the spindle does not get stimulated. So it inhibits to such stimulations. When it inhibits, it does not respond. It does not respond, it means it does not go in for reflex, sudden reflex contraction. It indicates that the muscle is getting relaxed. Or it is not going for a hyperactive contraction. When it doesn't go for hyperactive contraction, what will happen? It will not what do you call it will not initiate the other surrounding muscles. When it is not going to initiate other surrounding muscles, then there is less likely to create a spasm on the tone. When it is not happening over there, when the tone is getting released over structures, then probably your movement pattern will re-establish. Right. I just had one session previously. Alright. So probably let me check for the lateral flexions. Alright, I don't okay. Actually there's something here. Alright. So this lateral flexion is better than this lateral flexion. Alright. And passive rotation probably has is better, and I take a little extension. I find for the tone, right? I don't find anything great over here. Right. Now after relaxing, just I did not do anything now. After a couple of minutes of movements of other directions, I tell her just can you bend forwards, flexion in front. Okay, see the amount of flexion that has happened than previously. Release हो गया, so it is able to go front. Okay, but still there is tilt on this side. But these structures are still tight, so I have to probably work on some rotatory components. This side rotatory components are tight, this side rotatory components are weak. It's probably because there is one more point here that's actually creating you to pull this side. Unless I release this, it's not going to happen. So we'll think of releasing this also. Okay, this is your cervical flexion release. What we did now is a cervical extension release. Alright, what you will be doing now is a cervical flexion release. Alright, so what is the movement to be done? This is flexor in nature, it is supposed to be flexion, lateral flexion is the same side. Okay, and what this is on the sternocleidomastoid. So what is the actual sternocleidomastoid?
Same side.
This. Alright, so we keep it in this position, give a gentle pressure over here. So we keep the pressure and then do the movement passively and wait for about 30 to 60 seconds. Sorry, 30 to 90 seconds and then take the position off. Can anybody try on her for cervical flexion release? Can anybody try on cervical flexion release? You have a patient in front of you, not a model. And somebody mark it. Correct. This is what? Okay, I did not see, I did not ask. I identified and I could find there's a small change in the muscular, what you call the tissues over there. Okay, that's what skill of percussion you should be developing it. Unless you put your fingers on the tissues and keep moving and finding out the changes and the difference in the textures. Alright, you will not be. I didn't ask her, I just came down, tried 2-3 times and I found a difference and I could find palpation, I could get a trigger. Okay, I think she means bending her shoulder and the neck. I just fix it up. Okay, fine. Now you have to release it. Release it now. Yes. Yes, that's your point. Is it painful for you? No. Okay, it's supposed to be this. You should feel that. Wait. It's here. It's here. Put your finger. Give, don't give. See this. You find the difference here. You find it? That's your text you should identify. That's where you find the tightness behind. कैसा बोलना निकला? It's something like you have this छोटा
बूंदी जैसा है ना ये बॉडी हॉल
a nodule. Right? You find small elevation. As if
उसका फोड़ आया यहाँ पर
you have a
pimple. So if you imagine that you are running a finger on a pimple that is inside
your skin. Okay. Now what you do
for flexion release. Flexion release. Take it into flexion first. No. See. So once you palpated, always keep your hands. Get it relaxed. Just relax. Right. Right. So. Yeah. Painful. Alright. So I am on the pressure. I am on the structure. Flexing it. Okay. Lateral flexing it. How's the pain?
Terrible.
Alright. Okay. Fine. Is this?
No,
Huh?
that one was better.
Right. This?
Yes, it's less painful.
Is it X painful for you?
Yeah.
That's good enough. So probably for her, this is less pain. So the extension is causing her less amount of pain. I'm sure?
Yeah.
Okay. Extension plus lateral flexion, is it?
Yeah, this also.
This is okay?
Yeah.
No pain? Comfort is the most relieving. So sometimes maybe for her, it is going on the contrary of it. So it says usually is what it happens. Flexion always goes in flexion. Sometimes it may even go in flexion. So you should, that's the reason you should go in for this box effect. Find in which direction it is going to be less or more. Alright? Little amount of rotation. Now,
Yeah, this also less painful.
less pain. Alright, fine. I'm just really relaxing. The pressure on. It's good. I'm not doing anything. I'm just holding. So somebody can have the schedule of time, please, for 60 seconds. It's no pain. It's still done? Right. So once it is done, without taking the hands off, taking out the neutral, okay, kept it neutral, and then I give the contact off. Relax the muscles. That's fine. You can get up and sit my dear. Alright. Turn the side.
the easiest stuff.
Pain. Head.
I'm giving a pressure now. I'm actually putting my pressure on the vertebrae. It's painful now, a bit, but now the previous pressure. Alright, fine. Relax yourself. Alright, that's good.
That's fine then.
Bend yourself into flexion. Right. Okay.
Still. So, but her pain has actually
Reduced. And rotate it towards the side. Rotation has increased. This side is fully increased. That's good. Flexion. How much of flexion you can take up? First flexion and now
flexion. There's a change. Alright? There's a full flexion taking place now. Right.
That's good. So this is probably how we get neutral. What is
Neutral for a cervical spine. Is it lordosis?
That is straight spine.
Lordosis.
Lordosis. So
I
take cervical spine to lordosis. Okay. neck in neutral. Alright, and I stabilize both the shoulders. I push it down already. Alright, push it down and I push the neck. What I am doing now is now I am releasing my shoulders. So I was initially stretching down, shoulders down.
Trying making sure that the entire spine is being compressed.
When I release it, the shoulders come up. So this structure, these muscles have come up and I have already compressed it from above.
So the structures on this side, posteriorly, anteriorly, all are now compressed. It is something like
It's
jammed.
so your structures are compressed, but the side that is attaching those rods, the ropes, they become
Released, or there is no tone in that. When there is no
tone in the structure, naturally by way of proprioceptive releases, it will release. Okay, so I get her into neutral, cervicals, alright. I push it, so shoulders down, give a compression. This is called as crowding, alright, and I release the structure.
okay, this is again to be done in supine lying.
How do I do in supine lying? This
Lie down.
okay, so
I push her down. Just hold. Just keep it like this. Bit of extension. So I maintain that extension. I give a compression. Okay. Now I release the shoulders. Maintaining the extensions. Time the same of 60 seconds to 90 seconds. Okay, make sure that the patient does not feel symptoms of syncopes or bleeding when you are doing this, because there are most likely you may get vertebral artery compression taking place during this compression. However, the compression should not be more than approximately equal to 5 min, half a kg to 1 kg of load, not more than 2 kg of load at any point of time. Gentle pressure just to make sure that the sphincters are getting relaxed. Why are you fascinating so much?
So 60 seconds.
Yes. The experience and muscles are actually vibrating behind. Yeah, it's called as fasciculations. They're actually they're getting released. Now the fasciculations are stopped. Can you feel the difference? The muscle was actually twitching when I was doing compression. You have to release the pressure. Neutral. Right. Contacts off. Just relax the muscles. Right. Get up.
head of a femur.
So I just give a compression.
So this is the angle.
Is it?
So this is the
Compression. Right? Drop it. Come to this side for other leg. Come to the sides, come to the sides. Yes. Extension. Okay. And crowding.